Hi, welcome to the Orthobiologics Podcast. This is episode 5. I am your host, Dr. Trevor Turner, MD, RMSK, down at Georgia Bone and Joint. Our episode today is titled Too Young to Fail. In this episode, we have the privilege to be joined by Dr. Tom Nabity, who is based in Michigan. If you want to look him up at his clinic, you can find him at his website, which is regenerativeMedicineMichigan.com. So our topic for today is stem cell banking. Now, there's some controversy, of course, about where cells come from and where they shouldn't come from and how to store them. And then if they're stored, how to store them in such a way that they are, in fact, usable and living and available to use in the future. So that being said, I'm going to go ahead and let Dr. Nabity give you a brief summary of where he works and what he does, and also his expertise and his reason for being interested in this platform and this idea. Please go ahead.
Hi, Trevor. Thank you. So just a brief history of my background. I am a physiatrist, physical medicine and rehab specialist is my primary specialty, and then did subspecialty training in interventional pain management. Found my way into regenerative medicine, actually through patients, direct care, directing me to that care. They were demanding or were seeking alternatives to surgery, alternatives to simply blocking the pain. And by way of patient requesting information, I did some research and found out that it's something that fits my skill set, and decided to do more education into that. Once I started doing regenerative medicine, I had a colleague introduced me to a company that was banking adult stem cells, which is what got me interested into that field. And as I learned more for personal reasons, I thought it was something that I wanted to invest my financial or my healthcare for my own personal healthcare future. I thought it was something important to invest in. So after I did that, it became an easy thing to talk about for patients.
Yeah. So thanks so much, Tom. So you mentioned that, you were trained as a pain provider. And I thought one of the things you said was really interesting. And that was the reason that you got into this field is because you were no longer, or your patients maybe were no longer satisfied with strategies or treatments that just temporarily blocked some pain. And so obviously there's a distinction between blocking some pain and a longer term strategy, maybe to emphasize better functional outcomes. And I take it that's kind of what you mean when you're talking about a biologics or a regenerative medicine approach. Is that basically how you feel? Yeah. Okay,
Yeah.
great.
So it's both patients requesting it and my own personal belief that it's better. The hard part now is, you get in situations where certain, insurances aren't covering it, or it's just for whatever reason not available for patients. And so then you choose your best option, next option. So I haven't completely stopped doing conventional pain management either. But all things being equal, I would choose a regenerative route over a block the pain route every time.
And then that's great, but you used one other phrase that I kind of would want to key in on, and you had said my personal healthcare future, and so that's I think maybe a concept that well-informed patients are more and more interested in, because we see this generation of patients, even the current generation, they're living longer, they're exercising more. I've had patients come in and say, well, I don't want to retire because if I retire, then I've got nothing else to do. And then, I've got other people who are saying, well, I'm retiring early because I have so much to do and I
Right.
have to be so functional and so strong to do a lot of these things. And they're looking at this going, I have a lot of longevity and I have a lot of years to go. How can I optimize the way in which I spend or use that time? And so that's maybe where some of the concept plays in that we're going to talk about today. So when you talk about your healthcare future and you talk about, the best way to preserve that, I mean, explain to me what is the reason that a patient would be interested in banking their stem cells in the first place?
So I would say the first thing is orthopedics. So that's, while still experimental from an insurance standpoint, I think you and I would agree. Um, the science proves that it works. Nothing in healthcare works 100% of the time, but um, I've seen it. You've seen it. We treat people with regenerative orthopedic treatments like mesenchymal stem cell treatments, and they get better. Their MRIs get better. Their functional levels get better. Um, it definitely works for orthopedics. That's just the tip of the iceberg. So when we're talking about the future that these cells hold, it's not just treating orthopedic problems, which, even if that's all it ended up treating, is still worth the investment. But there's over, I think the last count, over 1,000 clinical trials, NIH sponsored, looking at everything that's globally termed an age-related disease, things that happen to us as we get older. Osteoarthritis is one of those things, but so is Alzheimer's disease, so is dementia, so is heart disease, so is COPD, lung disease. Our organs give out. Our organs are all derived from the same mesenchymal tissue. And so the stem cells that we're looking at are mesenchymal stem cells. And I would say there's two kind of take home points from the early studies, and they're both very intuitive. Younger stem cells perform better than older stem cells, and your stem cells are going to perform better than a donor stem cell. So if you can have access to your younger stem cells, that's going to give you a therapeutic advantage in the future.
And when you say so that raises a good point, because in a prior episode, Tom, we discussed what the meaning of autologous was, and we discussed what the difference was between cells that came from bone marrow versus fat versus trying, people who are opting to try and use off the shelf products like umbilical derived cells or other sources. I actually had a patient come in, and their father, who was in the room with them, is a young quarterback, and he actually asked me point blank, what about umbilical derived cells? And I kind of, that was one of the things I emphasized. I said, look, your son, is young and very, very healthy, and the power of his own autologous cells, or the power from the cells from his own body, are incredibly powerful. I mean, they're like a super powered up machine, and there's not a need to try and use other cells or tissue in this case, especially. But for you, when you say younger cells are better, I mean, tell me, we talk a little bit about decade cutoffs and about when cell populations start to decline, or maybe it's related to vascularity, how many blood vessels there are in a given site. So talk a little bit more detail about that, if you would.
Yeah, so that's not something I have. Like, I'm going to tell you what my opinion on that is. I don't want this to be taken as fact.
Okay.
Um, so, younger stem cells perform better than older stem cells uh, through what I believe to be the paracrine effect. So, I don't think these cells actually grow into tissues themselves. The research or the studies that I've read that have made me come to that conclusion are ones where we tag these cells with the radioisotope, something that can be tracked as it like ages. And essentially, after 3 to 6 months, all of those cells have been flushed out of the body.
Tom, will you go back to that? I think there may be some people who listen to this that hear the word radioisotope and they kind of go to another planet, like they're not sure what that means. So break that down.
Yeah, so radioisotope is like it's like an element that we can track. So radio, not being radio like active, like damaging, it just labels. It puts a label or a tracking device on a cell, so that then when we can scan it and we can see where that cell is. I don't know if that does an adequate job, but it's not
Yeah,
something
yeah.
that's damaging to the body. It's not an additive to the cell. It's just like putting like a tag on, like if you're tracking the migratory pattern of birds or something. It's like putting a tracer or a track on the bird, and then you can see where the bird's going.
Great. All right. And so, sorry. And so then you were
Yeah.
saying if you label cells for the purpose of looking at where they go or what they do, the importance of that, or the significance that that shows you, was what?
is that that cell is out of the body in 3 to 6 months. So it's not, this doesn't become this permanent ACL or this permanent cartilage or this long term. It doesn't have some sort of building block long term effect. But what we believe it does, or what the studies that I believe in and what I've learned is that it affects the other cells that are around it. So the long story short of that is you still need to be a healthy organism. It's about the organism's response to these cells. It's not necessarily the cells that are doing the hard labor, so to speak. So long story short is if you take somebody's umbilical cord cells, those umbilical cord cells are just going to have effect on that organism. That organism itself has to rebuild itself. So the same idea with your own young stem cells, they're only going to have their effect around the tissues that they're injected in. So to your question, younger stem cells perform better. I think they do a better job of releasing the chemicals, releasing the signals that tell the body to build itself.
Interesting. Great. And so let me ask you too. I mean, I think it's going to be natural that people say, okay, well, there may be 1,000 clinical trials going on, and I'm not really sure whether I'm going to be a candidate for one of those trials, or I'm not really sure when I'm going to need a procedure. When a patient comes into your office and they ask about banking their cells, I mean, and they say, well, I mean, how young should I be, or how old should I be, or is there some sort of cutoff after which it no longer makes sense for me to consider trying to draw or store them? How do you answer that question?
My answer to that question, I'd say it's too early for me to give you a hard cutoff. Um, in my like the simple example I give patients is, you still have decent stem cells when if you cut yourself, you heal in a reasonable time. We all have seen those patients that as they start to get older, they start to get more frail. Their cuts just last through, instead of the normal 2 week kind of healing time. It's like, yeah, that was a month and a half ago. That was 2 months ago. The thing still hasn't healed. All right, that organism's starting to shut down. Their stem cells are probably not real um, potent anymore. Whereas people that are still healing in a reasonable amount of time, yeah, that's healing is the process through stem cells. So
Some of the numbers we've seen in the data is that, or at least that I've seen in some studies, say that, there's kind of this area around maybe 55 or younger. And so there's people who speculate, well, is the health or the potency or the efficacy or the strength or endurance sort of the signaling mechanism, is it better when it's below that age? And I've tried to tell certain people. I mean, I've seen triathletes who are in their 60s, and they're fanatically healthy and they eat great and they're always working out. And I say, look, you at 60, even if I draw your cells, physiologically, your cells probably, act better than a 45-year-old couch potato who eats fast food and never leaves the couch and watches TV all day and has diabetes and smokes. So, I think your point is great about the fact that um, when you're trying to assess whether or not somebody's going to heal, it's really more than just age. Is age really a number, or not? And so, do you have anybody at this point who has banked cells and then come back and later used them, or not yet?
so I haven't had anybody that's used them yet. And the reason that we haven't is because we haven't been doing it long enough where that patient has probably changed significantly from a
Okay.
biologic standpoint. And right now, we can't culture expand those cells in the United States. And so, if we were to go back to the bank and use their cells, they would be gone. Meaning, we wouldn't have enough to use and still have some in storage. We would end up using them all. So it doesn't make sense from a clinical standpoint yet for any of the patients. One or two things should either have to change. More time would go by, and something would change in that patient's physiologic state where they would be better off going back in time and grabbing their younger stem cells to use, or the culture expansion laws change and we're able to use and culture expand those cells.
Yeah, that's very interesting. So yeah, I've had patients ask me about that, about, if their disease is severe, can they expand their cells? And, we have a discussion about one, compliance with the FDA and the law in the United States. Two, about people who have left the United States for treatment who are interested in that. And then three, just notions of whether or not trying to expand cells is going to introduce extra risk when it comes to sterility and infection, and how many of those cells are going to be viable and how you rewarm them, et cetera. So there's a lot of technical detail, I think, involved with that. And it'll be really fun and exciting to kind of see the way that the science and the regulatory and compliance issues unwind, as time goes on, and as people, either have gotten more data from these clinical trials, or who are really, interested in the opportunity to be able to use their own cells to have better outcomes than they otherwise, would with maybe some of the more conventional treatments that we've used for a longer time in medicine, that maybe, often, which now we're starting to get more data for, and we're looking back and we're, starting to think some of these things maybe that have been done for decades were not as healthy and not as good as maybe advertisers we thought they were. So when somebody comes in and talks to you about, banking their cells, and you're talking with them about trying to get a younger, healthier cell in case they have a physiologic change in the future, does anybody ever come in and say, well, Dr. Nabby, I want to know, I mean, when am I going to be able to use this cell? How long is it going to be? I mean, do you ever have come across that question?
Yeah, no, that's a good question, and the answer is we don't know at this point. I mean, you're investing in the future of these studies, and that was my comment earlier. That it is an investment, and similar to like a financial investment, there's risk with that. There is a potential that by banking these cells, there never really is a use for them in the future. It's not known at this point that it will certainly pan out. In my opinion, I think there's overwhelming evidence to say that yes, this is the future of medicine, and without a doubt, there'll be a use for these cells. Now we need to compare younger. So for example, I'm 42 years old now. I banked my 39-year-old stem cells. So for me, say 15 years from now, I want to use a stem cell to treat some orthopedic condition that I've developed, knee osteoarthritis. Is it better for me to use my 39-year-old, or at that time, are there studies that show that using human umbilical cord is better? I don't know yet. We need to do those studies. We haven't done any of those kind of cost or those kind of comparative analysis. I think, and I would hedge my bets on my 39-year-old healthy stem cells, thawed, culture expanded, and then re-injected in me is going to be better than using a donor umbilical cord. That's where I would put, if I was a betting man, that's where I would put my money. But we need to do the study and find out. We need to play the game.
Great. Yeah. And I think, it's always really satisfying to find an expert in the field that is giving you their opinion, but then beyond just what the data is or what they've read or what they believe, have enough conviction to actually say, yeah, I went ahead and did this myself because the evidence is so compelling. And I'm sure when your patients come in and they ask you or they consult with you about this option, it's much more powerful, for you to be able to say, well, let me tell you what my personal experience is. Can I ask, how did you figure out who you wanted to help you, and where to get your cells drawn, and how and where to have them stored? How did you navigate that?
Yeah. So at the time, there was only one other orthopedic surgeon in the area doing the stem cell banking for um, health reasons, not for any other reason, for cancer treatment or anything. So I went to him. It was a pretty easy decision.
Great. And then talk about, I mean, were you, as a patient, it's easier for us, I think, as physicians to be objective when it's, someone else that we're treating, or someone who's maybe not in your immediate family. But now that, the roles flipped and you became the patient, I mean, was there anything that you were nervous about? Was there anything that you had questions about in advance that you feel like a lot of your patients similarly ask before getting an aspiration or a harvesting procedure?
Yeah. It was quite. I guess what's the right word? But it validated what I'm telling my patients. What I was taught when I was taught how to, what the procedure is apparent, what it apparently feels like, and what you're going to experience. it validated everything I was telling my patients. So it was actually quite an easy experience. Honestly, I did it first thing in the morning. I was back to work 30 minutes later, and
Wow.
had very little and to almost no discomfort. I didn't use any kind of anesthesia, any Valium or anything like that for the procedure. And the only time I noticed any symptoms was if I was like sitting up against a hard back chair, or if I was doing sit-ups and, on a hard surface, when my area of the pelvis that we draw from, the posterior superior iliac spine, the very back side of your hip bone, when that would contact some sort of hard surface for about 4 or 5 days, I had discomfort, but that was all. It was actually quite, yeah, validating and very, very tolerable.
Yeah, that's fantastic. Yeah, because we have, I would say, common questions that we get from patients are, is this going to be incredibly painful because you're going to put either a needle or some kind of drill, even in certain cases, which actually we don't use here. Many people do, into my bone marrow. God, that's going to be, horribly painful. Part of my response to that is, when I was still in residency, I spent a month in the hematology oncology unit, and all we did was go all day long from bed to bed to draw bone marrow. And most of those people never got any kind of sedation at all. And then the next question is often, how deep can you get me? Can I get, do I need to be put totally out? Do I need general anesthesia? Is it like a colonoscopy, or I'm in some kind of twilight? And people are often, I think, surprised at how well and effectively this procedure can be done, especially if done under image guidance, and especially if done with a good local anesthetic block. And we've talked a little bit before on the show about anesthetics and how they affect viability of cells. So we have a protocol for that, but people tend to do quite well with it and also have very few, if any, complications. And I think a common question is what you brought up, where people say, well, am I going to have a lot of pain after the procedure, around the needle site? And usually, my response is that really has not been something that patients have complained of. I think if anything, people have, some pain around the injection site, so not the aspiration site, but the injection site for usually the next 72 hours or so. But really don't have significant pain from the place where the bone marrow gets drawn. It's nice to kind of hear a little bit about your story and hear that really was your experience as well. So another question that I would ask you, Tom, is we do get people. Some people are very very well educated, and they've been reading about these procedures, and they ask very sophisticated questions, and they have a great understanding of the purpose of biologics and why to use them. And they'll say, well, if I'm going to come in and have my cells drawn, and this sometimes extends beyond just bone marrow. Sometimes we're also talking about platelets for platelet rich plasma. And they'll say, well, how can I make sure that the draw that I get is the best yield, or is the best possible quality that I get? And different people kind of have different answers to that. But how do you counsel patients in that regard?
So yeah, and I think those are really important questions that hopefully our work with, you and I use the same processing lab. So our work with a processing lab similar to the ones that we're using, where we're actually doing an analysis of the draw, whether it's a bone marrow draw or a blood draw, prior to injecting, will help us tease out what exactly are the most important things to prep our patients properly. So that's the first variable I think we have some control over in getting the good outcomes is how potent is our product. And so the things I talk to my patients about: sleep, diet, exercise, and supplements. There's, I think, decent evidence to show that obviously good sleep does wonders for your body. So it's important to make sure you're getting adequate amounts of sleep. The diet, that data is all over the place. My consultation, my patients follow, a clean, whole foods type diet. Avoiding processed foods, avoiding fast foods, whether intermittent fasting, true intermittent fasting, where you're going days without eating, is necessary versus more of a time restricted feeding. I don't have a hard recommendation for my patients, but I do refer to a local nutritionist and say that that's oftentimes one of the recommendations that comes out of her consultation with them. And as far as supplements go, there's a lot of stem cell activator supplements on the market. I can't fully endorse one over many of the others. I can tell you, I don't think they hurt anything. The things that make sense to me are the basic building blocks, things like glucosamine, relatively higher doses of vitamin C, fish oil, um, uh, and then as far as exercise goes, I'm a high intensity interval training advocate. I do think that that makes a big difference. Uh, Again, there's a couple studies that show that that might be something that improves stem cell production and improves our harvest counts. But those are things that, as we really start to track and dive deep into this data, those are all the variables I would like us to be monitoring. The types of exercise, but that's what I'm telling my patients at this time.
Great. Yeah. And I think that's a great summary of not just what you do, but I think what a lot of other people out there practicing in the biologic space are considering when they consider really the holistic picture of someone's health, and not just, well, here's a supplement, this will be great. It's really a complex interaction, probably between diet as well as environment, and we often talk about exercise as well. And military guys in particular, I've noticed there was a type of therapy that was developed for military members who needed to counteract muscle atrophy even when they had weight bearing restrictions on their limb, and that's called blood flow restriction therapy, and it's a class one FDA medical device that's used under supervision. But it's interesting because if I see military guys here in the clinic, they'll come in and they'll say, hey, I need to get my PT or my blood flow restriction therapy. I need to do that on the day that I'm going to have my draw before I come in. And I tell them I think that's we help coordinate that for people. Is there a study that kind of shows that that's going to give you the best possible draw? No. But is there at least some theory or some science behind it? I think that there is some science or some theory to suggest why that's going to be helpful for people. And do you? There's a couple of other people that I've talked to now that have also said, maybe how or whether or not we give people any type of IV fluid is somehow related to whether or not they're going to have a successful draw. We do talk with people about being hydrated well, but have you noticed anything or have you read anything about that?
I have no. So there's two that after I finished my sentence that came to mind. One is hormone optimization as well. I think it's something we should evaluate people's hormone levels. And then two is IV hydration and IV vitamin therapy. I think there are definite reasons why that would make it important. I mean, the whole idea is to optimize the specimen, the organism, prior to drawing the cells that are going to be coming from that organism. It's a pretty simple concept, but the execution of that concept is, it's going to take just, I think, a lot of um, uh, assumptions. I don't know that we'll ever be able to do really good studies that identify one specific variable that changes between this subset of 1,000 people and that subset of 1,000 people, because there's so many variables that go into optimizing all of those variables that we just talked about.
Yeah, it's going to take a lot of dedicated, rigorous studies that it's difficult to control for all of the possible variables that are out there, I think. One other thing, I'm going to shift gears for just a second. So, Tom, we were talking about, filming this episode and talking about it before we sat down today. I think one of the things that you mentioned sounds, really innovative. And so when we talk with patients about, why we're a good fit. So, obviously we, feel like we're doing things at the highest level or at a very, elite level. It has to do with how sophisticated the image guidance is when we do their procedures, and really that's because we want to be very accurate and very convicted that if we're going to use a biologic preparation, that it's going where it needs to go to have the best effect, and that paracrine effect or that signaling effect is so important for the surrounding cells, even in that environment. And so you had mentioned something that you're starting to do or you're kind of looking at, and it's called a nanoscope. And we're a bit careful not to mention kind of a lot of proprietary, products or brands or things on the show. But tell us a little bit maybe about what is the nanoscope, and why would you consider using that to help patients get the best delivery of their biologic or their cellular preparation to the area they need it most.
Yeah. So, yeah, it's definitely something I try to touch on as far as the variables for each patient getting a good outcome. We just discussed one, and that's priming their body to be the best source of the stem cell as possible. The second is my technique, or our lab's technique, for concentrating that cell and putting it in a syringe for me. And then the third, and arguably most important, but I don't know that that truly is. I think I want it to be most important, because that's really where my skill comes in. It's how accurate am I at putting the cells right where they need to go. We know these cells
Sure.
move a little bit, but they pretty much stay in the tissues that you inject them into. So no matter how good I think I am, once that needle goes through the skin, I can't see the tip of that needle anymore. So I either need an X-ray machine or I need an ultrasound machine so I can watch my needle go right into the tissue. Well, what's even better than that would be is I can visualize the tissue similar to what you can when you're getting your scope done. Um, there are limits with that, with as far as you have to inflate the joint with some sort of fluid. When you're injecting that fluid in there, that's going to make your cells potentially drift further around. But if you can inflate the joint, use one of these nanoscopes, which is essentially putting your needle into the patient, and then instead of using an ultrasound probe to see the tip of your needle, there's actually a little camera on the tip of your needle. So you don't need that ultrasound machine. You can see the tissue, and you can see the tip of your needle, essentially touching that tissue, and um, it just is more accurate placement of that needle directly into the tissue, as well as diagnostically. You can diagnose conditions more accurately by actually visualizing the tissue rather than relying on an MRI or an ultrasound.
Yeah, and so sorry, when you say a camera, I mean, what is the size of this camera? I mean, how small does this have to be to access the joint and get to where you need to go?
Yeah, so it's pretty small. So when we're looking at needle sizes, we refer to them as gauges. The higher the gauge, the smaller the needle. So a 25 gauge needle is the smallest I ever use to inject. I usually use a 22 gauge because it allows me to get that thicker substance through a little bit easier. And these cameras were anywhere from a 16 to a 12 gauge. So they're larger than the needles that we use, but still much smaller than the conventional arthroscopic trocars, which are sized differently than needles.
Wow, so amazing. So you would be using that camera to actually look at things that maybe you couldn't otherwise see on ultrasound or MRI in your clinic. Is that what you're saying?
Yeah, in particular, structures in the knee, for example, with ultrasound, the ACL is extremely hard to visualize, impossible to visualize the entire length of the ACL. And this would be a device where diagnostically in the office, we could perform this procedure, visualize the ACL, and that's an important one for us, because if it's a complete rupture with the ACL, chances of it responding to a biologic aren't as good. Whereas if it's an incomplete, the chances are much better for it responding to a biologic. And MRI is what I have to utilize at that point in my office right now.
Yeah, and that's a great point because I think we have a tendency, or our society, for whatever reason, has a tendency to think of MRI as kind of like this gold standard that shows you everything, and it's great. And I laugh because we have a big practice here where we have six other orthopedic surgeons working, and we frequently, when we go to the OR, find things either on scope or either during a surgery where we find things that sometimes look worse or look different than they show up on an MRI. And so, we end up having those conversations, obviously, with patients after their procedure. But it just proves, or what that really says to me is that the power of having, maybe a micro, really tiny scope that you would be able to use possibly in the office without going to the OR would really make your diagnostic ability that much stronger. And then I think what you said is also make your ability to treat that much stronger. And if you look at Reddit or you look at, some of the other message boards that are out there, that example that you just gave me about, well, look, I have an ACL problem and, this is how big the gap is, or it's not all the fibers, or is it all the fibers or not? I mean, that's a common question because that's, an example I think of a procedure where, repairing ACLs, we have some good data behind them, but if somebody doesn't have a full thickness tear and they're wondering whether or not they have another option, we have to be able to prove whether or not that is a viable option. And I think part of that is improving the way that we diagnose. So that's really fascinating, really cool that that's something that you are starting to explore and even do in your office. I commend you for that because you're obviously sort of an innovator, which is really, really cool. Tom, we are going to kind of wrap up here for a little bit, but I just wanted to thank you so much for being on our show today for Too Young to Fail. And thank you for talking about your experiences with stem cell banking and when to do it and things that would otherwise kind of help people have the best chances for success. Anything else that you would like to leave us with from the regenerative medicine clinic in Michigan?
No, I guess the only other item that I was going to bring up and didn't was I haven't just banked myself, but I've banked multiple family members. My brother, I have an 18-year-old, now 19-year-old daughter. We banked her 18-year-old stem cells. So
Wow.
it is something that I truly do believe in. And if it's something you're considering, don't be afraid of the procedure. The procedure is the least, is the least, should be the least of your worries.
And certainly, if you're in the Michigan area or you're close by, please check out Dr. Tom Nabity and his website if you like. And if you're down here in the Southeast, please check out georgiaboneandjoints.org or check us out on Facebook, YouTube, podcast channel. We are happy to see patients both here and those that fly in to take advantage of the Atlanta airport. So thanks again for joining us on episode 5, Too Young to Fail. Again, I'm your host, Trevor Turner, MD, RMSK, on the Orthobiologics podcast.